Hello, everyone. I'm thrilled to be here today to welcome you to the sharing of our report for the good of us all, addressing the needs of unhoused neighbors, of our unhoused neighbors during the COVID-19 pandemic. My name is Colette Auerswald. I'm a faculty member at the UC Berkeley School of Public Health. I'm also a pediatrician and specialist in adolescent medicine. I took care of patients in San Francisco at UCSF and San Francisco General Hospital for 23 years. And for about the same amount of time, I've been an investigator working with youth experiencing homelessness and people in our community who work with them to advance their health and well-being. So I'm super proud to be here today along with this team of medical practitioners, public health practitioners, and social scientists. And we're all members of the UC Berkeley School of Public Health Community Action Team. That's responding from us as a state school of public health to the COVID pandemic here in California. What I'm really grateful to all of you who have joined. Welcome to those of you who are members of the press who are with us on Zoom, and welcome to those of you on Facebook watching our live stream. And for those of you who are watching the recording, thank you so much for watching. I want to thank Brea Watts, who is here from the Office of the Dean of the School of Public Health and is helping us with this press conference. Our format's going to be that a number of us are going to speak, members of the team. Our team's even larger, but we're going to have some colleagues of mine who are faculty, as well as members of the team who are medical students, graduate students, and undergraduates at Berkeley, talking about the important messages we'd like to share with you today. Then we'll take messages, questions from the press, and then questions from the Facebook feed. Today we want to have a chance to talk to you about the disparities in access to shelter in place that are taking place in our community here in the Bay Area, as well as statewide and nationally. The public health paradigm that we've all become familiar with requires that all of us physically distance, shelter in place, practice good hygiene, and wear masks. However, it is manifestly clear that people experiencing homelessness cannot follow these directives in encampments on the street or in large congregate shelters. So as a result, some of us are sheltering in place and some are not. Investigators at UPenn and at UCLA have shown us that based on available data, people experiencing homelessness are 2 to 3 times as likely to be hospitalized, 2 to 4 times more likely to require an ICU bed, and 2 to 3 times more likely to die as a result of COVID infection. We have next to no data on rates of infection in people experiencing homelessness, just like we have poor data nationally for everyone. So it's hard to understand exactly what's happening with the disparities, but recently 20% of patients with COVID at San Francisco General Hospital were actually homeless. So sheltering in place should not be a privilege, and people experiencing homelessness should be given access and supports so they can safely shelter in place, so they can quarantine or they can medically isolate. For most individuals, this will require low barrier hotel rooms or single occupancy hotels. For others, this will require additional resources and supports to help them safely shelter in place in their current housing. So to talk more about why this is so important, I'm going to pass the mic to my colleague, Jack Colford.
Thanks, Coco. My name is Jack Colford, and I have trained at Hopkins, Stanford, UC San Francisco as an infectious diseases physician and epidemiologist. I've worked in the ID epi field for the past 35 years, and delighted to be part of this team to try to help shed light on this issue. I'd like to focus on essentially the science behind why this issue is so important, why we need to provide shelter for people experiencing homelessness. You know, there's an important chain of events that occur when a person experiencing homelessness is unable to shelter in place, leading to further spread of COVID-19 and other conditions in the community. So it makes so much sense from an epidemiologic perspective that we provide the necessary and appropriate shelter. We've all heard the term flattening the curve. You know, I can't go to a party now without everybody already knowing what an epidemiologist is. That wasn't the case a year ago, but everybody understands that and understands what flattening the curve means. And what we'd like to help the community understand better, why flattening the curve really relies on doing that in all the different sub-communities of our population, and especially for persons experiencing homelessness. Several things result from proper shelter, and when there's appropriate hotel rooms or single occupancy rooms, that provides an important barrier to viral spread to others. It helps to preserve hospital services, because we all understand that the overwhelming tax, the burden on our hospital system that occurs from the disease spreading in our community is a key reason why this is such a deadly pandemic. It helps to protect healthcare workers and first responders who work with this population. It is going to help us end shelter-in-place orders for the entire community sooner if we can do this. And it's then safer for people who are uninfected to resume normal life sooner, this whole concept of reopening that the country is grappling with now. I also just want to mention the importance of testing availability for persons experiencing homelessness. For all the reasons we know we need testing in the general community, and all the more so in this population, but without it becoming a barrier to put up as a bottleneck towards the provision of rooms and single occupancy situations. We need to find the right kinds of rooms. And finally, we have to make sure that these persons receive the appropriate medical intervention for the clinical care that they need. Let me turn this over now to Brandon Chu.
Thank you, Jack. Good afternoon, everyone. I'm Brandon Chu, and I just want to reiterate what everyone has been saying and say that it's truly my pleasure to be doing this and enlightening this issue for a lot of people. I'm currently an undergraduate at UC Berkeley, majoring in public health and minoring in public policy and human rights. And throughout my time at Berkeley, I've always been really interested in researching issues that lie at the intersection of those fields. And that's how I kind of learned about the hepatitis A outbreak in San Diego more than 2 years ago. And I still remember it being one of the largest public health crises in California at the time. Hundreds of people, predominantly people experiencing homelessness, were being infected by hepatitis A. But what struck me the most were the unique vulnerabilities that they faced in addition to unsanitary living conditions. People experiencing homelessness typically suffer from chronic conditions like diabetes, HIV, and heart disease. They are also generally distrustful of political leaders and medical providers as a result of discrimination, stigma, and stereotypes. And 2 years later, this report demonstrates very clearly that these exact vulnerabilities are still present today, and they underscore the need to support our unhoused neighbors. And with that, I'll pass it over to Toshali.
Thanks, Brandon. Hi, my name is toshalikatyal, and I'm very honored to be invited to speak about this important issue today. I've studied public health and global poverty in practice at Berkeley and have been researching the impact of tobacco control policies in the formerly homeless communities in San Francisco for the past few years at UCSF. Many of the folks I work with are in the shelter system, and I know that they are in a higher risk because of their underlying chronic conditions and inability to shelter in place. Hygiene and physical distancing are difficult recommendations to follow when living conditions are unsafe and when isolation itself presents serious consequences for already marginalized communities due to systemic inequalities. Cities across California and the United States are currently working to mitigate the risks of community spread by using shelter staff to facilitate the movement of unhoused folks into vacant hotels, motels, and recreation centers. This will significantly reduce the density of individuals in shelters and prevent exposure. Places like Portland, Seattle, and LA County have installed and continue to refill outdoor hand washing stations, distribute hygiene kits with masks and sanitizers, and are partnering with first responders to conduct widespread testing in larger encampments. Cities where such proactive measures have not been taken and have continued to conduct sweeps of people experiencing homelessness against CDC guidelines have seen a significant increase in the number of cases in this population. San Francisco has been a national leader in issuing the shelter-in-place order. So we urge the Bay Area to continue to follow scientific practice and flatten the curve by immediately placing our unsheltered neighbors into hotel rooms to prevent another outbreak in this vulnerable population. I'm going to pass the mic on to my colleague, Matt.
Thank you, Toshali. Hi, my name is Matusiewicz. I am an undergraduate here at the University of California, Berkeley, studying biomedical engineering and public health. When I'm not a student, I'm an emergency financial services coordinator at a local housing nonprofit here in Oakland at the East Bay Asian Local Development Corporation. I'm working 5 days a week with families that are experiencing the crisis and the economic impact that COVID-19 has had on our communities. And in particular, a lot of low-income families. A lot of low-income families in general have family members that are considered essential and have high probability for contact because of their job, for example, in custodial services or in the food service industry. And they cannot shelter in place effectively. They're still having to experience contact with other people. If they don't have, to effectively shelter in place, they would risk losing their job and their sources of income. And when you're already unstably housed or not housed at all, this is really a precarious situation. And in particular with families that have children with them, this is a hard situation, especially with bringing it back to their family and spreading it to other members of the family. Families are also experiencing unstable housing or do not have housing, aren't often eligible for shelter spaces, and they often have to shelter in place with other families and use shared resources, which increases the risk of transmission. It makes quarantining sick family members virtually impossible. Some of the recommendations that we've been exploring as a team with the School of Public Health have been certainly giving families separate rooms in shelters if possible, or if that is impossible, giving safe housing with a private bathroom to control risk of spread. And then also making sure to pay particular attention to childcare for family members who otherwise would not be able to work if they didn't have childcare, and also providing educational technology when possible to allow family members to go to work, and for homeless children who already struggle with access to education to have a stronger link to school. And I'll pass it back to Coco, who may be speaking more on the youth.
Thank you so much, Matt. As a pediatrician, I'm really, it's so important for us to talk about what's happening with families as well as with youth. Something that people don't know is that the majority of unstably housed minors and youth are actually unsheltered. They're far more likely to be living outdoors than their adult homeless counterparts. And that's true both in the Bay Area and nationally. In addition to that, many youth couch surf. That means that they can't control their environment either where they're living, and may not be able to shelter in place, nor may be able to be staying in those couch surfing sites in a steady way. Finally, youth who are in shelters face different challenges. Youth are avoid adult shelters because of the question of safety, and now the concern in shelters regarding congregate settings is threatens many youth shelters. However, it's important to emphasize that many youth shelters are actually very small, and so they can continue to operate safely, sort of as large families staying together to shelter in place. But this requires a lot more resources for programs that are rare and not funded to operate 7 days a week, 24 hours a day, providing all food and all support for youth every single day of the week. So in order to respond to this, it's critical that that youth who are tied to programs be able to continue to access these programs. A lot of these programs nationally are being threatened with closure or closing because of fear that they cannot operate safely. Youth who are not currently in shelters and who are outside, which is the majority of youth, need to be able to access hotel rooms. However, those hotel rooms need to be dedicated to minors and separate space dedicated to youth, so that they can be safe and not be sheltered with adults. We also need to have continued space for emergency housing for youth. Youth living with their families in times of crisis are far more likely to be kicked out or to need to run away from unsafe situations. And so we need to continue to have spaces available for them to escape to, unlike adult shelters, which for the most part are being closed to new entries. Finally, families that are supporting youth experiencing homelessness by giving them a place to stay and couch surfing should receive financial support, and we should explore new models for housing youth, including host homes or kinship shelters. I'll pass it to the next speaker.
Thanks, Coco. Hi, everyone. My name is Haruna Aridomi, and I'm a medical and graduate student at the UC Berkeley and UCSF Joint Medical Program. I've been working a lot with people experiencing homelessness in my academic work through direct outreach for many years, both in Berkeley and in the Tenderloin, and most recently as a member of the Berkeley Outreach Coalition. Through my work with the Outreach Coalition, I've seen the enormous impact that COVID-19 is making among unsheltered residents. Many unsheltered folks are worried about becoming infected, confused on what shelter in place looks like when their home is outside, and are in need of resources that will allow them to follow physical distancing and hand washing protocols. Everyone should have the opportunity to move into individual housing so they can safely shelter in place, quarantine, or medically isolate. And the accommodations must be appropriate for people experiencing homelessness, as Professor Auerswald has mentioned at the start of the press conference. And for those who choose not to or cannot move into individual housing, we need to do our best in addressing their needs and preventing the spread of disease through various means. One being that we need to have enough public space and tents for physical distancing. We recommend halting sweeps, confiscations of tents and belongings, and the ticketing of towing of cars so that they can safely shelter in place. We recommend doing testing, symptom checks, and temperature checks during outreach. We also recommend ensuring the basic supply needs like food and water. So we want to ensure that those are met. And we also want to make sure that encampments in public spaces have more accessible sanitation measures, which my peer, Doug Martin, and Professor Graham will now talk more about.
Thanks, Haruna. Hi, everyone. My name is Doug Martin, and I'm a medical and graduate student at the UC Berkeley UCSF Joint Medical Program. I've been doing outreach with people experiencing homelessness for over 5 years, and my current research focuses on restroom access for people experiencing homelessness in San Francisco. I want to emphasize that even before the pandemic, people living on the street have faced extraordinary difficulties with accessing restrooms and maintaining personal hygiene. The main barriers are the fact that there is simply not enough public restrooms, that public restrooms have limited hours of operation and are closed at night, and that public restrooms are often broken down, not clean, and not stocked with supplies like soap and toilet paper. This means that people experiencing homelessness are sometimes forced to defecate and urinate outdoors and may not be able to clean their hands and bodies afterwards. Of course, having to do this can take a serious toll on one's mental health and sense of dignity, and in addition, it can also facilitate the spread of infectious disease. To cite a recent example that Brandon touched on earlier, inadequate hygiene and sanitation conditions contributed to the 2016-2018 hepatitis A outbreak in California, which was the largest Hep A outbreak in the USA in the past 20 years. Now, with the advent of COVID-19, the already insufficient restroom access has gotten even worse. Public restrooms in spaces like libraries and college campuses are now closed, and restrooms in private businesses such as cafes are also gone. As a result, the few remaining public restrooms are being used much more frequently, which means that the previously existing issues with cleanliness and maintenance are even further exacerbated. Now, we all know that frequent hand washing is one of our most important tools in the fight against COVID-19, but if people are unable to access working restrooms that are stocked with soap, then how can we expect them to follow these guidelines? It's clear to me that we need to address this with increased maintenance and upkeep for existing restrooms, as well as the provision of additional restrooms to areas where people experiencing homelessness live. And now, continuing this topic, I'd like to pass the mic to my research mentor, Jay Graham.
Thanks, Doug. So I'm just going to reiterate a couple of points. But first, my name is Jay Graham. I'm faculty at the UC Berkeley School of Public Health. I conduct research on the spread of infectious diseases in community settings. So the first point I just want to reiterate is that we've got to get beyond hygiene promotion, promoting hygiene behavior change messages without providing the necessary access to hardware needed during an infectious disease pandemic. So I'm talking about soap and water and just a conducive, enabling environment for proper hygiene. Without these things, it'll only leave people frustrated and unable to adhere to the guidelines that are being promoted. And then the second point I want to reiterate, which you've already heard, but I think is very important, that if we're to stop the spread of this virus in our community, it will be critical to provide access to hardware and infrastructural improvements. So what am I talking about? Hand washing stations, showers, toilets, laundry facilities, solid waste disposal. So we need these where needed, but also at the same time, recognizing the psychological and social determinants of appropriate hygiene behavior and how we can get those behaviors in practice. And as my colleague mentioned previously, Doug, provision of showers, clean water, and soap should meet or exceed minimum standards. And so we use United Nations humanitarian relief standards in our report, but in this case, we believe that we have to exceed these minimum standards, and we have to make this basic public health infrastructure accessible for all if we're going to stop the spread. And then finally, it's not only important to have these items available, but it will be critical to regularly maintain the cleanliness of facilities, and cleaning and disinfecting high-touch surfaces regularly is an important precaution to lower the risk of spread. And with that, I'll pass it to Sarah.
Thank you, Jay. Hello, everyone. My name is Sarah Ferrell, and I'm a graduate student at UC Berkeley, completing my Master of Public Health and my Master of Social Work. I want to underscore this point that during this pandemic, we're trying to prevent the spread of this virus so that we can save lives. And we know that housing is essential in this work, and that's part of why we are recommending efforts to move folks into hotels as quickly as possible. But without considering the details of the daily realities of people experiencing homelessness, we will not be able to house as many people, and lives are at stake. So these details, as enumerated in the report, are not superfluous details. They are essential to making any hotel program feasible and successful. So as a brief example, think about somebody who is unsheltered, living on the streets, and they have belongings like tents or blankets or generators. Those are actually critical for daily survival. And so if someone is offered, for instance, to quarantine in a hotel for 14 days, but they have to give up those resources, then when they enter back on the streets after 14 days, their life is at stake, and that does not feel like much of an option at all. Aside from those technical considerations, you cannot understate how essential it is to have high levels of trust and sense of safety for folks in this process. So the report enumerates all of these details that are going to be essential considerations in this process if we are going to make accommodations and processes that truly value the inherent dignity of all of our Bay Area residents. And with that, I'll pass it over to Kamran.
Thank you, Sarah, and thank you to all my colleagues, and thank you to everybody for being here today. My name is Kamran Abri. I'm a second-year medical student and graduate student at the UC Berkeley UCSF Joint Medical Program, doing my research on homelessness in the emergency department. In addition to my academic work, I've been working with people experiencing homelessness for around 6 years in both direct medical care as well as service provision in general. And I'm also a member of the Berkeley Outreach Coalition along with Haruna. I'm going to talk about a subject that I'm particularly passionate about, which is people with substance use disorders and harm reduction. This is a particularly visible topic for a variety of reasons. So I'll start off by saying that, one, this is a subgroup of people that is especially affected by stigma. Substance use disorder is not an indication of personal or moral failing, and that idea is damaging to people and is damaging to their care. People who use drugs are first and foremost people, and therefore deserve to be treated with dignity and provided the care that they need. Another reason that this is a highly visible topic in the current environment is because many people question the feasibility of enacting shelter in place and isolation and quarantine procedures with those with substance use disorders. To this, I say, first of all, stigma drives the assumption that people who use drugs are less interested in staying safe from COVID-19 than others. And I invite you to examine that assumption. And also treatment and management protocols recommended by national bodies, such as the American Society for Addiction Medicine, Substance Use and Mental Health Administration, as well as local bodies, including the SFDPH, for people who are being placed into single occupancy units during the pandemic have been very effective. And our recommendations within the report draw from these protocols. This is something I've chatted with folks in San Francisco, folks in Boston. I've heard from people in New York that these protocols have been highly effective. And I think I'm going to kick it back to Brea.
Yes, thank you so much. Thank you for all of our speakers for your work, your leadership, your research. It is greatly appreciated. At this time, we want to welcome questions from the press. And also, if you're watching on Facebook, you can leave questions in the comment section and we'll get those over to our panelists. And so how this will go is I will be watching, and if you are someone on the media, if you could just raise your hand and I will acknowledge you if you have a question and would like to speak. All right, so first up, I see Benjamin. Please go ahead and ask your question.
Yeah, hi guys. Thank you so much for doing this. It's immensely helpful. I work at the LA Times, and obviously the sort of complex, or what our homeless population looks like and how it's sort of affected people in LA has been, and we have sort of pushed forward opening shelters of, they're smaller than an MSC or a Union Rescue Mission, but I wonder, Dr. Colford, or I mean, anyone, how you, is there any way to have a shelter that is effective right now? Because it doesn't appear to be much political will around hotels, even as they open many of them. I think we're sort of accepting or realizing that that will be part of whatever solution, for the next year going forward. And then also, I mean, this is a separate topic, but in terms of testing, in your paper, you kind of talk a lot about everyone should be tested. Again, not something that they're capable of doing right now. And then you talk about sort of population testing. I wonder how that differs depending on, for you guys, people who are sort of living on Skid Row or, in the Tenderloin or in shelters. I mean, how those two different things, you would do them differently. So those are my two questions. I appreciate you guys doing this.
Thanks, Benjamin. Maybe I'll take the first one. The facts of physical distancing are just facts of physics. And it's hard to imagine in the way we do shelters now that we can ever solve that problem and have the right physical distancing. So that's why the push for the hotel room solution. Of course, about the MSC outbreak and all that and how poorly that is working. Coco, do you want to take the second question?
Yes. So just to reiterate what Jack said, we have some really great diagrams in our report showing that even though there's this kind of not very well documented 6-foot distance that beds have to be separated by, that a sneeze or a cough goes about 28 feet, and it's just not safe. So there are multiple reasons why congregate shelters are not safe. The only types of congregate settings that could be safe would be congregate settings where people actually have their own room and they might be sharing a bathroom or a kitchen. So there are multiple settings where people are in transitional housing where they have their own room, but they have a shared kitchen, they have a shared bathroom. Not ideal, but those folks should be able to stay in that kind of stable environment with their staff, continue to try to move on their goals, and then get individually delivered meals so that they're not using that communal kitchen, potentially have smaller groups of people assigned to single bathrooms, and increase janitorial services to clean those bathrooms very frequently, preferably every, couple hours. All that is expensive. It's far cheaper than an ICU stay of $75,000 a day. So all of those measures should be taking place, but there's really no way that we can imagine that congregate settings could be safe. We even thought about putting guidelines about how to mitigate congregate shelters, and we finally decided we had to remove them because we didn't want to appear to be able to endorse those kinds of dense settings that really just aren't safe. And if you wouldn't have your brother or your sister or your mother or your son stay there, you shouldn't have another human being stay there. The second issue around testing is really important. So it's kind of interesting. I am not on the inside around access to testing, but it does seem that testing is kind of on some level, like shelter in place seems to be a privilege. And there's been a lot on Twitter about how, if you're Tom Hanks, who we all love, you can get testing, but maybe other folks can't get testing. And there's, a town in Marin now, everyone's getting tested. How is that happening? And when folks are able to shelter in place in single family homes. So I think we have to make decisions about what we do with tests, and that the first group of people who should be able to be tested are the people who are not sheltering in place because they can't. And I know that there are entrepreneurs right now who are working on testing. We were contacted by an organization that is a high throughput testing lab, and they can do 30,000 tests. They've been discussing that with folks locally. And there are other folks like that in other parts of the country. So I don't want this to be a San Francisco testing issue or an LA testing issue. This is a testing issue nationally. And obviously communities are kind of caught in the middle between what has been decided nationally around testing, which created a bottleneck, and we should have a surfeit of tests, not a bottleneck. So blaming the mayor, or maybe blaming the city council, or blaming the governor in your state isn't really fair, because they're mediating something that they didn't have a lot of control over. But I think with limited supplies, we should make testing available first to people who can't shelter in place.
And just to be clear, would that be people who are unsheltered or are in some form of shelter?
Both.
Like a congregate setting?
Yeah, both. I don't consider congregate setting to be sheltering in place.
Got it.
If it's not if it's not shelter in place for you and me, it's not shelter in place. So shelter in place.
That clears it up. Thanks.
Yeah, safe. Please, Kevin. Oh, sorry, I went ahead and called on him, Brea. After this, it's your call. But Kevin is a friend in this work. You're on mute, Kevin.
Good. Hey, thanks. I appreciate your work in this. I really do. Thank you. The CDC says that spacing tents out adequately on the street can be effective. I found that people don't space very well. They're doing a very bad job of keeping distance on the street. What's your take on sanctioned encampments with case managers on site? which some of the cities are considering around here and have done in other locations.
Haruna, would you like to speak to that?
Sure, I can start, and then maybe Coco, you can add on. I think, yeah, it's been an issue both in Berkeley and probably across many other cities as well. I think it's the issue with not having enough public space. So, like we recommend in our document about, maybe creating more public space that would be really effective, such as by starting garbage removal processes. And also a lot of people I know in Berkeley, while going on outreach, I've seen people using one tent for like 5 people because there's not enough tents to go around. So we need to have more tents to begin with. And I think doing that can really help mitigate the spread of the disease in general. And it is our goal to have people who don't want to or choose not to go into isolation units in encampment settings, so that they do have access to more infrastructure in terms of sanitation and case management, like you mentioned.
Have you had any conversations with people about setting up sanctioned encampments with staff on hand to monitor them?
Not at the moment, but I do know that the city of Berkeley at least is trying to coordinate services with people who are already doing outreach. And so there's the BACS and the HOT team and the Berkeley Outreach Coalition activists that are going out there right now. So we're trying to coordinate who is going where, at what time, and what services they're providing. So that is in the works. Mm-hmm.
Thanks.
And I would just say that there are cities that have done a good job with that. And so those are described in the report. And that we absolutely describe encampments as a second choice from a public health standpoint. We strongly believe that everyone should have access to real shelter in place in a unit with a door and walls and your own bathroom so you can stay safe. But we also recognize, for reasons including the ones described by Sarah about people's belongings, people's dogs, people's pets, people's partners, that might not feel like an option. So we see encampments as a second choice, but also as a choice that could be much, much, much better, either through pallets or through having people get off of sidewalks and have parking lots. There's a lot of open space everywhere right now, a lot of open space. And so we should use that open space to keep us all safer.
Thank you. Thank you.
Coco, as you mentioned and described just some of these different ways that we can use space, there's a question that came in from Facebook around your suggestions for these new type of models, particularly for at-risk youth. Are there any current efforts that we could be supporting and supporting this population?
That is a awesome question. Thank you so much. There are a lot of models for at-risk youth, and so youth experiencing homelessness are very diverse, just like youth who aren't homeless. And so there are multiple trajectories to homelessness. And so different youth have different stories and different options, and we should be supporting all of them. We certainly have experienced nationally that that structural racism has led to disproportionate numbers of African-American youth who are homeless. And many of those youth, contrary to popular beliefs, are actually connected to their family, maybe not to their, their parents, or maybe there was suffering or violence in the family that led them not to be able to be with their primary caretakers. But often there are extended family networks that are connected to young people who don't have the resources to actually keep them at home. This gives me an opportunity to share the story of John. John is a wonderful young man who's actually on my research team. It's the first time I've hired a young person who's currently homeless to work on my research. I've hired and worked with a lot of people who are exiting homeless, but not anyone who's outside. And he joined our team in January. And since then, he's been outside about half the time, inside about the half the time. John is African-American. He grew up in Brooklyn. And like many young people in Brooklyn in the 80s, became homeless. 80s and 90s became homeless because of fires in apartment buildings that weren't well maintained. And so his family's been on state house since then. And he sent me a text today that I won't dig up right this second, saying, Coco, the policeman in Berkeley just told me that if I'm not wearing a mask, I'm going to be fined $1,000. That's not going to work. John doesn't have $1,000, and John doesn't have a choice, and John doesn't have masks. So we need to be sure that we're creating options to help John potentially live with his family. He has a loving family who cannot house him and cannot feed them because of poverty. But if the state gave them money, they could. So this kind of kinship model is possible for LGBTQ youth who are rejected by their family, who also are disproportionately represented. We could have host homes who could get support to bring youth in. And there are many, both straight and gay families who would be willing to do that, of course, in a way that would be safe and not lead to transmission. So I think we have to be creative and not think of youth as mini adults, and understand that there are ways of connecting them to safe, family-like environments that will help them reintegrate and have a safe transition to adulthood. I am so grateful to you for asking that question.
And thank you so much for your response. And so the next question we'll take is from Max.
Hi, thank you all so much for putting this on. So my question is about testing, and all the research and information on the ground is telling us how vulnerable homeless people are to this pandemic. And that should really mean that they are prioritized for testing, but testing is so scarce in that population. It seems right now that the testing amongst the homeless is relying basically on entrepreneurial partnerships with universities and research settings. Is that going to continue to be the case? Is it feasible to test people in that way, or where do we need to see people stepping up in order to make that effort effective?
I'll leave that open to anyone on the team who might want to speak. Okay, not here. I'm just wanting to share things. So I kind of think about this when I'm brushing my teeth, when I'm in the shower, when I'm sleeping. It's not simple. Again, there's a lot of politics to who's being tested. I think there's no doubt about it. There's also different paradigms for who should be tested. Some of them dictated by a medical paradigm. So who should be tested based on medical decisions, who should be tested based on public health decisions, who should be tested based on housing decisions, who should be tested based on what FEMA will reimburse, who should be tested because they might be going to jail, who should be tested because they live in Marin. So it's very, very complicated. I think from the point of view of being someone who has taken care mostly of patients who have very low resources, and knowing the disproportionate impact of infectious diseases on those populations in the HIV epidemic, which certainly in the Bay Area we're very familiar with, we know that unless we put the resources where the problem is, it's not going to get better. And so I know Kevin remembers, I know Jack remembers, I remember when there were just, you know, dozens of obituaries every day in San Francisco And now we're talking about vision zero and having no more HIV. I certainly hope it doesn't take 40 years with COVID, but it certainly seems like we've learned a lot of lessons. And so unless we invest in those issues, it's really critical. And we can't make the mistake that we made with HIV, where we focused so intensely on drugs and medicines and didn't pay attention to the psychosocial issues that were driving the epidemic. And finally, we stopped talking about, are we psychosocial or are we medical? And we realized we needed to do both. I absolutely want folks to keep looking at drugs for coronavirus, but we also need to look at the social factors. And unless we test the people who are the most vulnerable, we will not be safe.
Thank you so much. So the next question that we have is going to come from Erica.
Hi, Erica Barnett with the Huffington Post. Can someone comment on the CDC guidance that shelters redistribute guests so that they're 6 feet apart, and why specifically that's inadequate? And then my second related question is, has that guidance contributed to this problem that you've outlined in this report, that cities are spacing out existing congregate shelters instead of putting people in hotel rooms?
Do you want to speak to that, Jack or Jay?
I think you addressed it a little earlier, Coco. I would just go ahead with that again. Yeah, because we discussed it in the report.
I think that those guidelines were well-meaning, and I have tremendous respect for the CDC. It's always been one of my dream jobs to think about working at the CDC. It doesn't look like that's going to be part of my life. So I have great respect. I think people were going with the best possible recommendations in an epidemic that this feels like HIV accelerated by a factor of about 575. What we've gone through in 2 months is like what we went through in HIV from 1984 to 1992. It's just insane. So I think guidelines, and we say this in the report, that there are existing limitations due to the great speed with which this epidemic is advancing. The news cycle for this pandemic is 6 hours long. And I don't have to tell you reporters that. It's a 6-hour news cycle. And what happened yesterday is so old. And so that's true with the 6-foot guidelines. They seemed like a good idea. They initially actually said 3 to 6 feet. Ouch. Now they say 6. And really even twice that, with sheets hanging between beds, which is another thing that people have described, and which was one of those like mitigating in between things that we were struggling with as late as yesterday. Do we put this in? Do we not? But, I think if I wouldn't put my mother there, or my brother, or my 23-year-old daughter, I cannot say it's okay. It's not okay. So I think people have to get out of congregate shelters into places where they have their own room. It could be dorms, it could be hotels, it could be YMCAs. There are a lot of options. It's cheaper than leaving them there. It's much cheaper. And then we can talk about congregate shelters for people who have recovered. The catch there, and this is where it'd be good to have a virologist, is that coronavirus does lead to immunity. So if you just got discharged from San Francisco General and you had coronavirus, you're going to be okay being with other people who also are immune, but we don't know for how long. And unfortunately, coronavirus, it's not like a measles shot where you're covered maybe for 20 or 25 years. We just don't know if it's going to be months or years. And so given that we're talking about an epidemic where we're going to go up and down, it's possible that people who are initially immune will not be, but we honestly don't know.
And Eric, I'll just add on to that. I mean, yeah. The great vacancy in all these hotel rooms. I mean, we have the stock is there for that.
Many cities have more hotel rooms than actually people being in those hotel rooms right now, I would add. And I'm not pointing to any one city for this report. This report is really intended to inform all communities, especially communities that are hotspots for both homelessness and COVID. But many communities don't, in part because they're doing just like we do in homelessness in general. And I know Kevin and others who cover this issue, because we're caught in this paradigm of deservedness. And right now, every biologic organism that is human should be sheltered in place, regardless of whether they're medically vulnerable or not. That does not mean that if I have someone who's 80 on the street, and there are folks who are on the shelter list who are 80, and they have my 23-year-old daughter and she's homeless, that I don't think that 80-year-old person should get that one room. But if there are 2,000 rooms that are open in a city, then the people who, we need to get people in those rooms immediately, and we shouldn't be worrying about who has the correct staff and getting the highest risk people in first. We should just get people in and keep getting rooms and just keep moving. It's just like, you know, getting traffic over the Bay Bridge. You know, just want to keep the cars moving. We're not deciding who goes across the bridge based on what kind of car they have. Just everyone's got to get there.
Okay, the next question that we have is from Noah.
Hi there, I'll turn my camera on, so yeah, you guys can you hear me? I had my mic off before. Can you further explain what surveillance testing is, and can you comment on whether San Francisco is or should be doing it?
Jack, do you want to speak to that?
Well, the broad concept of surveillance is following in a population, we say longitudinally over time, what's changing. So at a given point in time, what proportion of the population is currently infected, and what proportion of the population has already been exposed. And then a week later, 2 weeks later, 3 weeks later, Noah, how is that trending? What's happening? Because it tends to move in predictable ways when we know enough about the past experience. And maybe you're alluding here to the issue of the two different types of tests that are going on, the kind of morass that's happening with antibody testing, with the many different tests that are out there, and the poor accuracy of most of them to tell us who's been infected. Doesn't necessarily tell us who's immune and won't get it again for sure. And then the kind of current testing, the PCR testing, or the, you know, looking for the current viral particles that you're infected now. So there are kind of two strategies to testing related to the surveillance.
So from reading the report, maybe I just want to make sure that I understand it. Surveillance testing is about conducting targeted tests from within subsets of the population in order to track the spread over time, because you test weight.
That's right. And, you know, so we stratify the population into different sort of high risk groups, and we definitely want to make sure we're testing there. And then for the broader population, we can't test anywhere near enough people, but we do random samples when we can. That's, you know, you're reading about the Stanford study that just happened, and the Bolinas study trying to capture a whole population and so forth.
And this seems like an appropriate response to, if you don't have enough tests, obviously, to test everybody.
That's right.
So then you would
kind of to target them. Yeah.
Mm-hmm. Do you know if there are certain cities that are doing that effectively or that are not?
I do not know that. Coco, do you?
People are ramping up to do it. I don't know of any city that's got any kind of surveillance testing with population-wide testing of the general population, or any rates of infection for people experiencing homelessness in any setting whatsoever at this point. You know, people are, there's tons of funding going out. So I do think that the funding community, both private and public, are doing a lot, and there's tons of movement, and that's going to change in a few days. I know that there's a big study looking at a large chunk of the Mission District to try to understand rates of infection and determinants of infection in the Mission District in San Francisco as kind of a sub piece. So there's a lot of work being done, including by the Benioff Homelessness and Housing Institute that I'm affiliated with at UCSF, but nothing available right now. Again, this is just to compare this to HIV for something that's only been around, you know, for a relatively short amount of time. Even if we said, well, we've had this since December maybe, or February or January, this would be really, really fast. It's just that our expectations are through the roof because it does make a difference how quickly we move. And literally, we've seen that cities that have moved 1 week later have a lot more suffering and death.
Do you mind if I ask a follow-up question?
Just I'm conscious of the time and that our broader folks, so if you want to put it in the chat, maybe I could answer.
Okay.
Super respectful of your joining, but just to give everyone a chance.
Absolutely.
Yeah, and thank you so much, Coco. Actually, as you're speaking on our broader audience, there's a question from Facebook in regards to building structures and housing. Is it possible to start with tents and build those on platforms for everyone in need? Maybe even smaller homes, tiny homes housing. There's a mention that this was successfully done in 1906 after the SF earthquake. And is there anything similar that we learned from that experience that we can do now?
Would someone like to respond to that?
I can make a quick comment about it. I mean, the one thing I would say specifically is, yes, that is a way to create units, but also we have units. In the case of the 1906 earthquake, the city was leveled, right, and those units didn't exist, and we needed to create new ones. In this case, we have empty single occupancy units in the city. So from an infrastructure standpoint, it's much simpler to use those rather than to go through the effort of obtaining tents, planning where to place the tents, making sure that we have better, we have distance between the tents and that we can cordon off new public spaces to put those. We have walled off units, and we have infrastructure around that already.
I think because of the urgency, it's really important for people to just move. We saw in MSC South that from, which is a shelter in San Francisco, sorry to speak in acronyms, there's a shelter in San Francisco that had an outbreak that was a very well documented outbreak. On a Wednesday, there were 5 cases. By Friday, 48 hours later, there were 78 cases from the same total number of tents, and by the following number of people, and by the following Monday, there were 103 cases. So even for tiny homes that can be built, in a day, or getting tents, it's really just much better on the super short term to move people into hotels. Obviously, people shouldn't live their lives in hotels, and hotels hopefully eventually will actually, be able to travel and will be able to have tourists in different places. But I think in terms of trying to harvest the silver lining in an enormous tragedy, if we could see this as an opportunity to put the kind of the structural violence and physical abuse of people who live outside on pause, on a very slight pause, by giving everyone a place to stay that's safe, by having their humanity be acknowledged, by just having a chance to just be inside and rest. And we have heard from folks who have that opportunity. I know one of my colleagues said that she was doing a study, but she spoke to a woman who was 74 who got in a hotel room and slept in a bed for the first time in 5 years. Just feel what that's like. How old is your mother? So giving that woman a chance to sleep in a bed and to rest and to put it on pause, maybe at the end of this time, she might be able to reconnect and to stabilize enough so that after this period of stabilization, and I have to emphasize that people experiencing homelessness, just like my 92-year-old mother, have to be the last to exit shelter in place. After all the bumps, after everything, when we feel comfortable that my mom can go to a dinner party with 40 people is when people should exit. And so at that point, hopefully we'll be in a different place, and those folks could exit not to the street, but to their lives and to moving on. And so that would be my hope.
Okay, and it is now 3 p.m. Coco, would you like to take one more question or would you want to wrap up?
I just really want to thank, first of all, my colleagues, our dean at the School of Public Health, Michael Liu, who reached out to us before shelter in place even hit in San Francisco, first city that that took that on, and said that our school really had to be sure to step up. I want to thank my colleagues and the students that I work with. This absolutely would not have been possible without people's passion. No one is doing this for recognition or for money. I think everybody feels really called to respond, in multiple fields, but certainly in public health. I'm incredibly inspired by the response of the media. And I have to say that that's been really incredible. It hasn't, like in a lot of crises, been kind of a search for scapegoats, including people experiencing homelessness, that the media has responded also with just, incredible dedication to this. So again, I think if we don't harvest the silver linings from this very, 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 very dark cloud, I don't think any silver lining will make this worth it. But if we don't try to harvest that, it'll be a tragedy. And I do think that the inspiring response from so many sectors, it will make it worth it to get up tomorrow morning. So I guess that's all I can say. I do want to thank Brea also, who just got totally, we were just like, please do this, you'd be awesome. So thank you for doing this and helping us. And do feel free to reach out to us. We want this information to get out there, and you guys are the best people to help us do it. So let's partner.
Okay, and with that being said, just to reiterate with Coco, thank you for your time and your leadership with all of the speakers that we've had today. Thank you to the press for joining, as well as to all of you guys who are watching from Facebook. This meeting will be recorded and available on our public health website within a few days. So just give us some time to do processing, and then we'll upload the video as well as take all of your questions and comments into consideration.
Thank you, everybody. Great work. I'm very proud.